we're going to do a very brief report out from the discussion that just concluded. We will have a sort of longer report out and synthesis tomorrow, and our goal for tomorrow is to really move things forward in terms of generalizable principles. But while it's fresh in our mind, what we wanted to do was to ask each of our discussants to sort of nominate their top sort of 2 or 3 points that they wanted to make sure got into the record as something important that got said in the discussion. So I'll let Jesse go first on that.
Okay, the 3 most important things are validation, validation, and validation. And against what is one of the questions that we raised, so that sometimes our gold standard may not be so gold. But I think it would be nice to have a library of kind of validated algorithms to allow us to do some of these larger scale studies. And then the other point I want to make sure we get is the nature of the misclassification matters. So if it's differential, if people are more likely to attribute an event to one treatment than the other, that has one kind of consequence. If there's random misclassification, then you'll underestimate effect sizes, which is bad enough for effectiveness or efficacy. It's really bad if you're looking at a safety issue, a harm. Underestimating the effect could be really detrimental. And if you're trying to look at non-inferiority, then that kind of bias is also a bad thing.
Okay, so I'll have a little different take, but similar themes, but trust, transparency, and verify. And what I mean by trust is that there is an accumulation of data that shows, for example, like how you define certain populations or how you can define outcomes. So you should use that, but then also verify, especially if there's something that's changed by the context or time there. Regarding transparency, I think that can also be helpful so that results can be easily understood, they can be interpreted, they can be reproduced, but also even extending beyond in terms of transparency. So if there is more transparency in terms of how data is being created and how that may vary, say, across different health systems or different data systems, and there's attention towards quality through that transparency, that can be really good. And in the clinical world, the context is for quality improvement, we didn't really pay a lot of attention to certain areas in terms of quality improvement. At Duke, for instance, we knew we were really good, but then when there's starting to be public reporting for either outcomes or either process measures, it was a little humbling to find out that we were just average, and actually we weren't even better than UNC, which was a change. But what we did, though, is start paying a ton of attention towards the quality of our data and the quality of our care. And so through that transparency, we did affect change, and so that came from the outside. And so I think the same thing can happen for real-world evidence.
Yeah, and as a UNC alum, I do have to always remind Adrian of who won the NCAA championship last year, although he'll probably get me next time. So the points I would want to underline, one is, going back to sort of, Rob's point about, let's not pretend that the old emperor really has clothes, to realize that, we don't want to sort of, put up on a pedestal the existing way of assessing outcomes or assessing clinical phenomena. Some of the ways we have traditionally done things are quite good. Some are quite problematic. We don't want to lump them all together and say that they're acceptable. And that when we think about our sort of process of improvement, we are really trying to simultaneously improve the quality of data that support clinical practice and to use those data for continuous learning. I remember there was a meeting sort of several years ago. I think it was the first time I met Rob in person. It was one of those early meetings about use of the data exhaust from clinical practice to do research. And there was a lot of discussion over and over again about the problems with real-world data and the problems with EHR data and problems with the validity of EHR data. And, you know, I couldn't help but, you know, ask the question, you know, what we're saying is these data that are coming out of clinical practice are not nearly good enough to do research. They're only good enough for some unimportant activity like taking care of patients. The point being that everyone will benefit if we can do a better job of this, and that the whole idea of computable phenotypes, algorithms to define meaningful clinical phenomena, and ultimately to predict and anticipate clinical need, big healthcare systems are on that right now. You know, this is kind of a big deal in the healthcare delivery world, not just in the research world. So we need to bring those activities together. So the other thing that I thought was important to underline is, to me, I took away from the discussion, it's not a sharp distinction, but I still think a useful distinction of the difference between sort of clinical and technical sources of error. By clinical, I mean, you know, we believe that there was a human being on the spot who made a judgment, and we think that maybe wasn't the right judgment. And a technical is more that, you know, there is a technical problem in the way those data are recorded that leads to some systematic error that we need to fix, because our ways of tracking down those two kinds of error are different.
One thing, Greg, to emphasize your point about the data being good enough for practice versus research. So for most health systems, it's at most 2% are enrolled in a clinical trial. So it's the 98% that you have data for which you're doing clinical practice, but ignoring, say, for research potentially.
So that's our report out for today. This group will be coming back tomorrow and engaging you in some more, can we move forward with some rules. But what I want to do now is move on to our next session, and Khalid Sarsar, who's going to introduce our panelists.